The roll.
Representative Bentley. Here. Representative Bratcher. Here. Representative Bray. Representative Burke.
Here.
Representative Callaway.
Here.
Representative Duval. Representative Fraser Gordon.
Here.
Representative Justice. Representative Neighbors. Here. Representative Rayborn. Representative Raymer. Here. Representative Riley. Representative Rorks.
Present.
Representative Sharp.
Present.
Representative Swan.
Here.
Representative Weber.
Here.
Representative Wilner. Representative Whitten.
Here.
Representative Dotson. And Chair Mosier.
I am here, and I do know that we have a few members who will be trickling in from another meeting as well. At this time, I'll hand it over to my co-chair, Senator Meredith, for the Senate.
Thank you, Madam Chair, and would like to welcome everyone as well. Our second meeting there in the Central, and certainly the first one was very informational and entertaining as well, and I expect the same thing today. Obviously, we have a full agenda. And with that, Becky, if you will, please call the roll.
Senator Rocky Adams, Senator Berg, Senator Carroll, Senator Funky Fromeyer,
Present.
Senator Nemes,
Present.
Senator Titchener,
Here.
Senator Wise, Senator Douglas,
Present.
Chairman Meredith.
President, if I could, please allow me the opportunity to introduce our Senate committee staff because they are invaluable to us. And I'm not sure how many newbies we have from the Senate side, but to my left, raise your hand if you would, Chris Joffrin, who's our lead staff person, and to my right, Becky Lancaster, who's our committee assistant. So again, as you're working through various bills and issues with this committee, these are the all-stars here. So I want you to know their faces. So thank you. Madam Chair, back to you.
Thank you, Senator Meredith. And I'd like to introduce our House staff. We have Deanne Wenk, who is the lead staff for our committee and all things healthcare. And DJ Burns is the committee assistant. And we also have some analysts who it's important for you all to know. And they will be working with both the House and the Senate. We have Ben Payne, if you could raise your hands, Samir Nasir, and Logan Bush. Okay. So for all the new legislators, when you have questions or comments during the meeting, please signal one of the staff. You probably gathered that from the last time, but we didn't say it. And they'll put your name on the list to ask questions during committee. So, okay. Well, thank you all. We will go ahead and get started. We have a very full agenda, as we tend to do in this committee, but I felt like this topic was very important, not only to those of us who are serving here, but for members of the public to hear an update on the opioid issue. We hear a lot about it in the news. We hear a lot about it in our communities. Our families have been touched greatly by this issue. And I just want everyone to know that a lot of the initiatives that you're going to hear about today all stemmed from some policy decisions that we made here, either on a state level or some of these initiatives even began on a local level and became some state policies that we enacted. So I know that it's going to seem like a lot of information. Just try to absorb as much as you can. Again, there are always individuals and members of various departments who you can reach out to ask questions, get more information. So this is meant to be kind of a broad overview. And certainly this is something that's near and dear to my heart. I work on this a lot. So feel free to reach out to any of us if you have questions. So first, we would like to welcome Mr. Brian Hubbard, who is the Executive Director and Chair of the Kentucky Opioid Abatement Advisory Commission. He is with the Attorney General's office. And if you could just introduce yourself for the record. I see that you don't have anyone with you. I was going to say introduce any guests, but you don't have to do that.
Thank
and
you,
welcome.
Madam Chair. My name is Brian Hubbard, and I am the Chair and Executive Director of the Kentucky Opioid Abatement Advisory Commission, and it is an honor to be in front of the people's representatives this afternoon. I've been asked to provide an overview of what the Commission is, the purposes that it aims to achieve, and the things that we have done so far. As everyone here likely knows, we have achieved a settlement with various opioid manufacturers and distributors to the tune of $842 million to date. This includes what we refer to as the Big Three and Johnson & Johnson, which yielded an initial sum of $478 million earlier in the calendar year 2022. This was part of a $26 billion global settlement process in which multiple states participated, and it is the second largest such settlement in U.S. history. The distributors involved in that initial sum were AmerisourceBergen, Cardinal Health, and McKesson, and manufacturer Janssen, which is known as Johnson & Johnson. During the month of December, additional settlements were achieved with CVS to the tune of $93,753,135.58, Walgreens in the amount of $102,811,226.12, Walmart for $53,513,897, and then with Teva Allergan for $115,017,509.70 to Kentucky. Pursuant to House Bill 427, which is codified at KRS Chapter 15, 291 and 293, these funds are to be distributed pursuant to the arrangements set forth by the legislature.
Brian, if I could interrupt you for a second, can you just pull your microphone a little bit closer?
Sure.
Thank you.
How's that? Thank you. The $842 million will be dispersed annually on various schedules through 2038. 50% of this money will be distributed through a prearranged formula to our political subdivisions consisting of the counties, cities, and towns. 50% of the funds will come to the Commission, which will be distributed by grant awards. Senate Bill 90 will require the distribution of $10.5 million annually from the Commission share for 4 years for the behavioral health conditional dismissal program that is being developed in connection with the Administrative Office of the Courts. All funds, whether to local governments or to the Commission, must be used for opioid abatement. And KRS 15291, subsection 5, lists possible programs for use of those funds. The Commission's composition is of 6 individuals who are appointed by Attorney General Cameron, and then other members who are prescribed by statute based on position. Those who have been appointed by the Attorney General include myself, Dr. Jason Roop, who represents victims of the opioid epidemic, Director of the Office of Drug Control Policy, Van Ingram, who represents Drug Treatment and Prevention Community, Mr. Vic Brown, who is the Executive Director of the Appalachian High Intensity Drug Trafficking Area Task Force, Ms. Von Purdy, who is a Vice President with Simmons College in Louisville, Kentucky, who represents Citizens at Large, and then Ms. Karen Butcher, who also represents Citizens at Large. Ms. Butcher lost a son to fentanyl poisoning in May of 2021. Other members of the Commission include State Treasurer Allison Ball, Representative Danny Bentley, who has been appointed by the Speaker of the House, Mr. Carlos Cameron, who has been appointed by Senate President Stivers, Dr. Sharon Walsh, who has been appointed by the University of Kentucky as part of its Healing Community Studies team, and then CHFS Secretary Eric Friedlander. Between the Commission's first meeting, which occurred on July the 15th, and the beginning of October, we worked very diligently to create a grant application which could then be uploaded onto an electronic platform for the purposes of developing the necessary infrastructure to receive grant proposals for review with an eye toward making awards hopefully within the spring of this year. We had models that we worked with that ranged anywhere from a 2-page document that lacked very critical components of due diligence that we think were required to review the viability of applying organizations, as well as the necessary financial disclosure and performance measures that we thought we needed to have in order to assure accountability and transparency. On the other end of the spectrum, we had a 450-page monstrosity that came from a western state that had clearly been created by the collaborative and creative exercises of a lot of lawyerly minds. So we tried to cut it down the middle and came up with a 15-page document, if you print it out on Word, that we now have put onto the electronic platform that was activated for the purposes of submitting grant proposals on October the 17th. And I would like to congratulate my colleagues on moving by what by government standards would be lightning speed to have had a first meeting on July the 15th and a grant application activated in just over 90 days. We have a situation whereby an organization or agency that is in good standing with the Kentucky Secretary of State may apply. We intend to do everything we can to be creative, entrepreneurial in our philosophy, and to explore every opportunity to develop innovation with regard to combating the opioid epidemic. There is no deadline for the submission of grant applications. We are accepting these on a rolling, open-ended deadline. There are no caps on grant requests, and the funds will come through the settlement disbursements over 18 years, and we hope that we will have somewhere in the neighborhood of $30 to $45 million to work with for calendar year 2023. And again, we have a target date for our first round of awards for spring of this year. You will see if you go to the Attorney General's website, there is a yellow banner at the very top that an individual or organization may click on that will take them to the grant portal, which is highlighted there in orange. Since the Commission's formation, in addition to its regular business meetings, the creation of the application, as well as the electronic portal through which they are being submitted, we have had 11 exceptional town hall meetings across the state, literally from Pikeville to Paducah. We went to Louisville twice, we've been to Paducah twice, and we just had our second Lexington Town Hall event at Consolidated Baptist Church on Tuesday evening. Thus far, we have received 32 completed grant applications, and there are an additional 231 in progress. And as you can see from that bottom line figure, the total ask among the 32 completed grant applications is $63.6 million. That concludes the formal part of this presentation, and any questions or comments are certainly welcome.
Well, thank you for that brief overview. I know that a lot more work has gone into this than you made it sound like, and you've been very busy with the commission. And I thank you for all your efforts. I know that you've been busy going around the state doing town hall meetings. What are the recurrent themes that you're hearing in and around the state, and is there any clear direction for disbursement of these funds programmatically?
If it's okay, I'm going to answer this in 3 parts, and the first will be the big picture perspective. What we have gathered is that in our town hall meetings, it is very clear that Kentuckians wish for those of us who hold public trust to understand the depth and just immense dimension of pain that exists in the state that has been produced by this epidemic. We are losing a small town a year and have been for at least a decade. The other thing that has become apparent is that for as awful as these conditions are, you may have heard the notion that for every action, there is an equal and opposite reaction. There is no question but that this state has a tremendous, organic, and stalwart grassroots immune system that is kicked into high gear to do everything that is available and by any means necessary to try to beat the opioid epidemic. And that has been one of the most beautiful things to emerge from the very extreme set of circumstances that we have in the state when it comes to the death and damage that's been created by this epidemic. We have a treatment infrastructure that appears to be robust. The best of structures can always use expansion and improvement. But the front end, as it pertains to prevention services, specifically prevention services that are oriented toward children whose families and communities have been devastated by the opioid epidemic, and recovery services for those who are just now beginning the process of rebuilding their lives, or those areas in which we seem to have the most critical gaps. Whether we are talking about recovery housing that is genuinely safe and sober, whether we are talking about transportation, the expungement of criminal records, the creation of viable employment opportunities that let people have a dignified life, all of these remain significant challenges that we need to address, and those are the consistent themes that have come through the most wherever we have been in the state. I will add one other, and this is kindly grabbing a hold of the third rail, but it's necessary to articulate it. There has been for a long time a belief that the opioid epidemic is a uniquely Caucasian problem, particularly as expressed in our state as it began in eastern Kentucky. 2021 was the first year in which black Kentuckians were charted and statistically demonstrated to be dying at a higher rate than that of whites. And those deaths are almost exclusively driven by fentanyl poisoning that began to really show up in state statistics in 2017. And the trend line is a sharp trend line upward. And it is something that we have got to get our hands around and drive awareness of. It was news to us when we pulled those statistics, and everywhere we have been to give a presentation of statistical realities, it has landed like a thud in the middle of a room. And that's something that everybody should be aware of.
Thank you. I appreciate that very much. Dr. Douglas, Senator Douglas.
Thank you, Madam Chair, Madam Co-Chair. Mr. Hubbard, I have a couple of questions, if I may, Madam Co-Chair. I have two questions. You're exactly right that Black America, we're discovering, is dying at a higher rate from the fentanyl, and some of the earlier studies suggested that it was white America that was primarily involved in methamphetamine changes. This is an area, as you know, I've worked in for a long time. I have two quick questions. We've mentioned that there are no caps on the award, and my first question is, how do we determine the efficacy of the pre-award program? How do we determine how well that program, or how much are we going to give this particular program and this particular program and this particular program before we give it to them? That's question number one. And if I may, I'll throw this out so everyone else can hear this one too. The second question is there going to be a cap on attorney fees, either as a percentage of the grant or award, or as a cap on the attorney fees for the total amount of that particular award? I want to see this money going to where it's going to affect our public and not to attorneys' fees, with all due respect to attorneys. And maybe you could help me out in these two particular areas. Thank you, Madam Co-Chair.
Let me answer that second question first. And with all due respect to my fellow lawyers in the room, I am not made uncomfortable by any disrespecting of lawyers you may wish to offer. The attorney fees have already been deducted from the settlement proceeds at the national level. There were multiple law firms engaged in the negotiations. There is a settlement administrator that is named Brown and Greer that is overseeing the distribution of the money as well as the deduction of those fees. In terms of the commission's pot of money, that money is arriving after those deductions have occurred as part of the national settlement process. So there's not going to be any money heading to any lawyer bank accounts from this commission. In terms of the first question, we want to make sure, and as best we can tell, given how the statute is written, the legislature has been very forward-thinking in terms of wishing to have a structure that preserves local autonomy that allows cities and counties to customize solutions for their unique conditions on the ground, while giving the Commission specific statutory guidance as to those priorities on which the money must be spent, without pigeonholing the Commission to certain rubrics that may or may not fit our state. The way in which we intend to award money is on the basis of the priorities that have been identified within the broad topics of prevention, treatment, and recovery. Insofar as we have grassroots organizations that have a demonstrated track record based on their ongoing current work as well as their past performance of delivering services that fill in those critical gaps that were previously described, that is what is going to drive the award of the money, is fulfilling the need that is identified with grassroots organizations that have proven track records of performance that consequentially address the gaps in service that we need.
Thank you, Mr. Hubbard.
Thank you, Senator.
Senator Meredith.
Thank you, Madam Chair, and thank you, Brian, for your presentation. You always do a great job. Just a couple of quick questions for. 842 million is a nice number, but it's relatively small when you look at the scope of the problem. And any discussion about going forward about what the price tag might be for this and where additional funding might have to come from? I mean, could it be from the general fund, or is there anything else that's kind of hanging out there that we need to pursue?
First of all, thank you for acknowledging the very obvious reality about the availability of resource when it comes to a measurement against need. And while $842 million sure does sound like a big mountain of money to the regular ear, including my own, when we consider the fact that Purdue Pharma cleared $100 million a month for years on the sale of OxyContin, this state is going to receive over 18 years what that company, which created this problem, cleared in just a little over 8 months. So what we really have here, while substantial and while very much needed, is but a drop in the bucket compared to the overall scope of this problem. In terms of finding additional funds with which to address the opioid epidemic, there are still yet potential lawsuits to participate in, either as part of a national litigation and settlement process, as well as the consideration of litigation within the state. Those are not things that at this stage in the game there have been any firm decisions on, because they're very much in a stage of development and assessment. The one thing we have to look for is the opportunity to build a clinical treatment paradigm that covers us from front to back, that will deliver us better results than what we have now. I don't have the answer as to what that is, but just as the United States relied upon a team of scientists spread across the country as part of what was referred to as the Manhattan Project, hopefully at some point in time we will be presented with our own Manhattan Project opportunity, so that we can determine whether or not there is something out there on the cutting edge that gives us a fighting chance to win this thing. There are thousands of people engaged in consequential work that goes directly to the saving of lives. All options that show any promise for doing that should be on the table and be ready to be deployed as soon as they can be put on the ground and deployed.
Appreciate you mentioning Purdue Pharma. That was interesting, the numbers you gave with CBS, Walgreens, and so forth. Certainly great settlements. I think the Purdue Pharma settlement was 26 million, I believe, possibly 29. And I understood at one time that former Attorney General Stumbo said that this is going to be $1 billion settlement in that suit, and we weren't even close to that. But it is tragic that they made that kind of profit, that we just kind of get a pittance of it, and that's very tragic in itself. But I appreciate your assessment of this, and certainly be a challenge going forward. But thank you.
Thank you, Senator.
Okay. Well, thank you again. I really appreciate your work, your comments today, and we will certainly keep working together on this. I know that we share this passion for really finding some solutions to mitigating and mitigating the problem and saving more lives. So, all right. Well, I think at this point I don't have any further questions for you right now. Doesn't mean that there won't be later, but I think at this point we'll bring up Dr. Katie Marks to talk about the CORES project and funding the Kentucky Opioid Response Effort project, and all of these kind of go hand in hand. So it's my hope that after you hear all of these presentations that you'll get a clearer picture of what's going on in Kentucky. So Dr. Marks, thank you so much for being with us today. If you could introduce yourself for the record, give us your title, and tell us about the great work that you're doing. And I haven't seen your slides yet, so hopefully there's a little bit of background. If not, provide that. Thank you.
I appreciate it. Thank you. Katie Marks. I'm the project director for the Kentucky Opioid Response Effort. CORE, as we call it, is housed in our Department for Behavioral Health, Developmental, and Intellectual Disabilities within the Cabinet for Health and Family Services. I'll be full of acronyms, and I'll attempt to also spell them out as we go through the project today. I want to just pause and thank you for prioritizing this topic. And I know today is centrally focused on it, but what I see is a continual prioritization of this issue in our policies, in our discussions, and the ongoing dialogue that we have, and that makes the difference, I think, in our state. I also hope that you'll hear in this presentation today, as Brian so eloquently described, both the challenge that Kentucky is uniquely facing in the opioid crisis, but the immense array of solutions and recovery that is already occurring in the state. And when I tell you we are leading the nation in the solutions to the overdose epidemic, to the addiction crisis, that is the truth. And so I'm going to paint a broad picture of many things we're already doing today with the goal of continuing to scale the work across the state. CORE was originally funded through SAMHSA, the Substance Abuse and Mental Health Services Agency, in 2017, and they came with a very intentional focus and set of funds to reduce opioid overdose deaths across the state and also increase access to a full continuum of prevention, treatment, and recovery support services. And so that's where CORE is born from, is that very specific grant initiative. We receive funding every 2 years from SAMHSA. It requires regular reapproval from Congress, and so we just began the 4th iteration of what we call the State Opioid Response Grant. And so as you can see, our mission is guided by a bigger purpose, which is not just reducing overdose deaths, but building a recovery-oriented system of care to implement a full continuum of interventions and services. I wanted to quickly paint a picture of our funding for you. As you can see on the left is the name of the grant. Sometimes you'll hear people talk about CORE, and you'll hear people talk about SOR, S-O-R, the State Opioid Response. These are interchangeable terms. But this shows you that we are receive a significant investment, but at the same time, we just had a conversation about the scale and the insufficiency of these funds to make the statewide impact that we need. Nevertheless, what's really unique about this opportunity, and has been since it began, is the ability to pilot, develop, test, and evaluate novel interventions, and then work to build them into policy and practice by expanding our reimbursement structures, by changing statewide practices so that these aren't just one-off pilot projects, but a changed way that we have our system of care. What we do with this funding is create funding of opportunities on an annual basis to award to community partners, and over 92% of these funds go directly to community partners for delivery of services. The remaining portion is also to state agencies to directly deliver services, and then a small portion is the operation of CORE. You can think about CORE as an anchor to a really broad array of community collaborators. And so while we are housed functionally in the Department for Behavioral Health within the Cabinet of Health and Family Services, our partnerships are immense. In fact, I could name most people in this room by name because we work closely on an initiative. So between the Justice and Public Safety Cabinet with Van Ingram and the Office of Drug Control Policy, DOC, our AOC partners that are going to present, the work with Recovery Ready communities, our universities like the Healing Community Study that I'm sure you've heard of, and the vast array of community partners. This is bigger than just a set of funding and a set of awards. This is a uniting collaborative around what works and coordinating, collaborating our efforts. My background is academia, so I can't help but give you at least one or two frameworks for how we think about what we're doing, because when you understand what our approach is, it makes sense what our solutions are. And so we use the cascade of care framework, and what it says is that we think about all the points along the continuum of care that we have the opportunity to intervene. And so we can begin by preventing the initiation of use, but we also have to prevent that transition to misuse. We have to identify the need for treatment early, and we have to provide treatment access and engage people in that treatment. Then we have to support them in the retention of treatment and then sustain remission and long-term recovery. And so we have to target each of those phases at the individual level. And then we also have to build that continuum into all of the systems and settings that we deliver services in. So it's no small task. Across all of this, you see is reduce harm. The principle of harm reduction is simple. It doesn't deny or minimize the real and tragic harms of substance use, but what it says is that we have the opportunity to also care for people and give them dignity and opportunities for health and wellness in the future. And so we can provide that reduction of harm throughout the continuum. And then at the same time, we're going to build personal, family, and community capital. We're going to build resilience and protective factors so that we can prevent the cycle from continuing. And when we think about building out our system, and I think this is applicable to every project in this room, it's not just about creating more services. It's not just about the availability. We have to ask, are they accessible? Is it someplace someone can get to? Can they afford it? And not just is it available and can they access it, is it person-centered? Is it what that person needs for their recovery? And then is it quality and evidence-based? And we have to tick those boxes, all four of them, in order to change our system. Just to bring it back to core a little bit more specifically, our priority populations are based on the data that we have that show who's at highest risk for overdose. And so we've prioritized at this time 4 populations. People who've experienced an opioid overdose, we know that they are at highest risk for a subsequent overdose. Pregnant and parenting women, both for the vulnerability and the opportunity to impact intergenerational families. Criminal, legal involved individuals, we know not only that the reasons they often enter the criminal legal system is related to their substance use, but their vulnerability to return to use and overdose following release from incarceration is immensely elevated. And then marginalized and minoritized individuals. I'll give Brian another prop for thank you for very clearly stating the change that we have to address, which is that our Black Kentuckians are now dying at a higher rate than white Kentuckians of overdose. So I'm going to spend the last 10 minutes or so just walking through the different initiatives and programs that CORE is funding. And what I hope you'll hear from this is just a little bit to pique your interest. I guarantee you I could go on for hours about each of these projects, and they all deserve the attention, but I just want to highlight a few that are really exciting. So I start with infrastructure because this is the building block for how we create access and availability and accessibility and quality. And so this can range from training of our clinicians to building workforce capacity, training peer support specialists, developing central registries to be able to help facilitate quality methadone treatment. But 2 that I really want to focus in on for you are, first, the Unshame campaign. Stigma is one of the major drivers of why people don't seek treatment, don't remain in treatment, or return to use and then don't seek services after that. And so Unshame Kentucky is a statewide anti-stigma campaign. It's focused on reducing the stigma against addiction. It's reducing the stigma against medications for opioid use disorder. You'll hear me call that MOUD several times throughout. The statistics are remarkable on this. On a monthly basis, this is just December data, 1.6 million impressions on social media. So this is largely driven by videos that Kentuckians record about their journey, their experience of hope and recovery and remission. You'll recognize Marta Miranda Staub as one of the people that has contributed to this campaign. On a daily basis, 600,000 people are watching these videos, and I think that this is really an impactful initiative. In version 2.0, we're going to dive even deeper into fentanyl awareness. And follow us, Unshamed Kentucky. You can follow us on social media. You can go to the website. Please help expand this. Another infrastructure initiative is the Kentucky Recovery Housing Network. This is the adoption of the National Alliance of Recovery Residence Standards to build a system of certification that supports safe and quality housing. It also provides technical assistance for free to any recovery housing operator, a monthly learning collaborative call. It has a community advisory board. Right now, we've got 42 houses certified that hold up to 496 beds, and an additional 109 Oxford houses that are not counted in this number. You'll hear me talk about housing, and I'm sure you'll hear about others as well. We have a significant deficit in recovery. We have a housing deficit to begin with, and a recovery housing deficit on top of this. And so the Recovery Housing Network is one critical intervention to make sure that we've got safe, quality housing. I'm going to move into prevention and harm reduction strategies and just a foreshadow, then we'll go through treatment and then recovery. There's so many important initiatives. I'll talk about naloxone distribution in a little bit, but know that we do a lot with primary prevention, which means prevention in our schools and after schools. Over 300 schools have adopted some of the programs that we funded. Sources of Strength, or Too Good for Drugs, community coalition building, early childhood mental health services to support bonding and early attachment, syringe service programs, reducing suicide risk. All of these are distinct initiatives that have specific projects, contracts, and partners in our community that are doing this work. But I want you to know especially about overdose education and naloxone distribution. So naloxone is the generic name for Narcan, which is the overdose reversal medication. Narcan has remarkable capacity and efficacy in reducing an opioid-related overdose, and it's one of the most important interventions we can get out there to save lives, because we can't help people recover if they are not alive. And so we've got a two-pronged strategy. We have both community-based distribution, which means we pay directly for the cost of naloxone, and we give it to health departments and community-based programs and jails and schools to say, here, you can have this to give directly to the people you serve or to give directly to individuals. And we also work with our pharmacies, and we encourage co-prescribing, pharmacist-initiated conversations about using naloxone. And this is all anchored by the Kentucky Pharmacists Association and done in very close coordination with all of the funding for naloxone in the state. So between Office of Drug Control Policy, CDC funding, state block grant dollars, we make sure that this is a coordinated effort anchored in the Kentucky Pharmacists Association. On an annual basis, we're getting out about 63,000 two-dose units of naloxone a year. That's almost half of the statewide distribution. There's a lot of national discussion about what it's going to take to get to saturation, which means that we have enough naloxone out there for everyone. And what I can tell you is that we're scratching the surface. We're still scratching the surface. I also wanted to highlight syringe service program expansion. We know unequivocally that syringe service programs save lives, they reduce disease transmission, and they facilitate service access. And so what we do is just use very small amounts of funding, $15,000 to $30,000 awarded to health departments, which are the entities that oversee the syringe service program. And the return on investment is remarkable. 8,700 individuals last year alone accepted a referral to treatment because of their engagement in a syringe service program. 98,000 brochures went out around education, around harm reduction, wound care and protection, and accessing treatment services. And just for your own visualization, all of the stars represent where we have syringe service programs in Kentucky, and the pink is where we have counties vulnerable to an HIV or a Hep C outbreak. In the treatment space, as you heard me say earlier, we're focused on outreach, engagement, access, and retention. Treatment isn't a single unidimensional concept. Quick response teams are funded throughout the state. The idea here is that when someone experiences an overdose or opioid-related crisis, we send a team into the community to show up at their door alongside with the EMS at the hospital to the family to say, we're here for you. We're going to connect you with resources. One of the things we learned, especially during COVID, is that we can't wait for people to come into our brick and mortar buildings. We have to go out there in the community and meet people where they're at, figuratively and literally, and that's what quick response teams do. About 25% of people access services as a result of the quick response teams. That's a huge return on investment for something we hadn't previously invested in at all. CORE also pays for treatment for individuals who have no payer source. We pay for residential and intensive outpatient services. We pay for room and board to extend the duration of their care. We pay for methadone when there's not a payer source. We worked with the Kentucky Primary Care Association to fund federally qualified health centers and rural health clinics to expand their capacity to offer services within their clinics. We have worked with hospitals and now have a partnership with the Kentucky Hospital Association to expand a bridge clinic model, wherein if you come to an emergency department or the hospital in general after an overdose, you have a peer support specialist on site that says, I'm here to help link you to services. The hospital treats opioid withdrawal that day in the hospital, and then we connect them to care by physically transporting them or bringing them back to the hospital where they can be in a bridge clinic for a period of time. Mobile treatment, mobile methadone, these are all activities that we are currently funding and are expanding in this state. I always have to emphasize medications for opioid use disorder. We know that the evidence is absolutely clear and is embedded in all of our projects. Medications reduce opioid use craving, return to use, overdose, recidivism. They improve treatment retention. And I'll back up and say that medications for opioid use disorder refers to buprenorphine or Suboxone, methadone, and Vivitrol. And the last piece, just to emphasize in the treatment space, is our partnership with addressing the criminal legal system. And so I've laid out for you quickly so that you could read it another time, this idea that at every intercept of the criminal legal system, whether it be when they're still at community services and law enforcement, all the way to reentry into the community, there are core funded programs building services for people, whether it be pretrial care coordination, alternative sentencing with funding to support access to treatment, medications in the jails, or reentry care coordination and employment and job training for jails or people reentering. The service continuum is really remarkable in its breadth. I'll leave these for you to read, but a 42% reduction in opioid use disorder diagnosed at 6 months. That's our primary outcome right now with CORE. For people that complete a survey at the intake, which is several thousand individuals at 6 months, we've got a 42% reduction in opioid use disorder diagnosis. About 13,000 unduplicated individuals are served each year. In the recovery space, recovery is maybe the most exciting piece to talk about because it's not just about the reduction in use or the cessation of use. It's about that opportunity for employment and stable housing and connecting back with your community and family. And so we use this term recovery capital instead of just recovery to talk about those resources that people need to build in the protections and the reinforcers that help them to stay in long-term recovery. And so access to recovery is one example of a program where CORE will use funding to pay for those non-reimbursable recovery support services, recovery housing, transportation, job training, so that people in early recovery can build that recovery capital and stay in long-term recovery. We pay for recovery housing. We also have supported recovery housing operators to build new programs, and we've built out an immense amount of mutual aid groups across the state. And these are just a few of our primary recovery outcomes. Know that there's another about 13,000 individuals each year that receive recovery support services through CORE-funded programs, over 1,500 people receiving housing just through Oxford House alone, remarkable number of people, almost 5,000 individuals getting employment support services, and a 199% increase in employment from when they enter a CORE-funded program until 6 months later. And so I really wish that I could just dive deeply into to every last program, but I'll leave it for kind of future conversation and obviously more discussion right now. But I hope that this provides the flavor of the array of services and the understanding that there are evidence-based practices implemented in the state that are working, and it is our job and opportunity to scale that which works. It's no longer just a scarcity crisis. We have effective programs and partners, and our job is to turn it over to them to do that work at this point. So with that, I'll take questions. Thank you.
Thank you so much. I mean, I am always impressed when I hear you speak about the programs that we're implementing in Kentucky. We've done a lot of good work on implementing policies, and you've been a good partner with us to really identify what's working, what isn't. I love that you do a great job on following up and really giving us some of the outcomes that we need to really see what's working. I was part of that little quick response team program years and years ago up in northern Kentucky, so I'm excited to see that that's expanding. And one thing you said that it's being funded through the state, and that wasn't always the case. Do you mean that some of those programs are being funded through the CORES program?
Yeah, I tend
Okay.
to use that. But we also have expanded, so there's now block grant funding, so SAMHSA block grant funding that also goes to that. And then emergency, the CARA ARPA, we've used that to also, so expanding.
Okay,
Yeah.
good. And it's exciting to see that 25% return on investment. I mean, that's a big number of people who wouldn't ordinarily seek treatment. So there are some good things happening. The bridge expansion, that was, lots and lots of meetings early on to really encourage physicians to prescribe buprenorphine in the emergency room. So there are these programs that started small and through a lot of really great partnerships are growing. So I find it very exciting. I have a question about the NAR certification for transitional housing. And I know that not all of our housing needs to be, or there's no real requirement to be NARS certified. Is that something that you think would really help us as we're looking for quality programs? I know that there are cities and counties who deal with kind of these pop-up sober living houses. That's a terrible term, but that's, and they're not certified. And, they create a little bit of distrust, I would say, in the communities. What are your thoughts about any sort of requirement or even an incentive to be certified?
Yeah, so we established NAR certification anticipating that this type of conversation was coming, and we've used the carrot approach, I think, is as far as we can go. And one of the main carrots, in addition to the training and technical assistance, is that with CORE and also with DBH, Department for Behavioral Health Funds, is we say we will only award funding to NAR certified, or entities can only refer to NAR certified. And so that's the biggest, I think, payoff, is really routing people to quality programs. The reality is that there are going to be bad actors, and the bad actors that don't want to be NAR certified are just not going to apply. And so I think the biggest fears we have about recovery housing are going to be continue to play out because they're issues bigger than the recovery housing. They're often exploiting people in those cases and already violating other existing laws that need to be regulated. And so this relatively narrow space of people that houses that need to become NAR certified, I do think that if we can get a groundswell of support by having more entities require it and really pushing people towards that NAR certification one way or the other, we are going to see a positive return on investment. But I think we just need to recognize that those entities that don't want to be certified, that aren't going to play by the rules, this isn't going to make the big difference for them. No.
Okay, thank you. Yeah, I mean, I think that makes a lot of sense. I'm looking for ways to not only create quality treatment and wraparound and reentry services, but give our communities some comfort that these are, folks who are following the laws and are working to improve their lives.
And good neighbors.
100%.
Yeah.
Okay. And then I have a question about a reg that we talked about in the summer. It had to do with the 300 patient limit on treatment providers. where's the cabinet on this right now? And I mean, I'll probably have a follow-up.
I wish I had brought Rachel to the stand with me. She could speak to it much better than I know that it was just the reg just went all the way through. The 300 was returned back to the previous state, so I am blanking on exactly, but there was no change in its status from what it was prior to opening the reg. Could I invite Rachel for a
Sure,
response?
yeah. Rachel, do
could I invite you?
you have any more information? Yeah, sorry. Sorry, Rachel. Always be ready here. Rachel, if you could just quickly introduce yourself, that would help.
Rachel Ratliff. I'm the Regulation Coordinator for the Department for Behavioral Health, Developmental, and Intellectual Disabilities.
Thank you.
The reg actually cleared ours for its first reading last week, and we had, in the drafting of it, we had, of course, made changes to restrict that to 300 patients nationally. And what we did was we opened up more prescribers and providers that are available in clinics to where it's not just a program physician or a program prescriber, but we allowed other professionals that qualified based upon their credentialing and their licensing. So those are available to do up to 300 at the location that they serve.
Okay,
So
so, yeah, so what I'm hearing is you actually expand the number of providers, but
Yes,
kept
ma'am.
the cap.
Yes, ma'am.
Okay.
And removed the national requirement as well. So there's no longer any cap across state borders.
Yeah.
So glad
Oh,
you-
I see. So if a provider comes from out of state. Yeah, I mean, I still, I'm not crazy about this idea because we don't cap the number of patients for other specialists. So this is a reg for everyone on the committee that we'll be hearing, and so we'll have another opportunity to discuss it. But this is kind of the process. We get feedback, and you've already gone through the public comment period, and you've digested all of that information and come back with your proposal. So thank you for that explanation. We might have more questions, but I appreciate that feedback.
Yes.
Okay, thank you. All right, Senator Adams, do you have a question?
Yes, thank you, Madam Chair. I have well, one question you already asked was about state participating in this. Is it just a federal funding, or did the state contribute? But I'm curious to know, I'm assuming that the footprint of this is statewide?
It is.
Okay, so we have a statewide footprint for this, and there are a lot of programs that you outlined. But I'm interested in kind of the breakdown of the numbers of what are we spending most of this money toward? And I know we kind of glossed over outcomes. Do we need to look at those percentages of what we're spending that money on to get the higher level of outcomes? Because this is a lot of money, and we still have a very pervasive problem in our state. And so I want to make sure that we're utilizing resources where we can see most advantage.
Absolutely. So about 53% of the funding for CORE is to treat what you call kind of classic treatment. About 19%, I'm saying about 19%, it's exactly 19% because it is harm reduction. So that would be either naloxone distribution or syringe, naloxone distribution or other harm reduction activities. About 5% is primary prevention. Sorry, I didn't move these in order. Primary is 5, 19 is harm reduction. Treatment is 53, and so the balance of that, with the exception of 5% infrastructure, is recovery. The reason 53% is treatment is because a lot of these services are Medicaid reimbursable. And so our first responsibility is to not duplicate existing funding sources. So while someone might expect that this should be 75 or 80% treatment, we're really just filling in the gaps of where insurance leaves off. Recovery support services, on the other hand, there's functionally no reimbursement structure, so you would expect to see, and I've lost track of my numbers, about 25%, maybe a little bit more, 30% of the funding being recovery oriented.
Okay, can I have one follow-up, Madam Chair? Do we have a breakdown of geography about where the funds are in what part of the state?
We do, and I can get that to you afterwards, and an array of different visualizations. But in general, where we started is mapping it onto overdose deaths by county, and so we created a risk index score. What that score has showed us over the years is that our urban centers, Louisville, Lexington, Northern Kentucky, and then Eastern Kentucky historically have received the majority of the resources that's proportionate to the impact. We've seen two things change over time, though. Shifting to more central Kentucky, so if we start with kind of Fayette County, move a little east, and then do a big circle like this. So funding is increasingly allocated in that way, and then more towards Western Kentucky as well. SAMHSA expanded our capacity to also provide services for people with stimulant use disorders, and that was historically a little bit more represented in Western Kentucky, and so Western Kentucky is increasing. But yeah, I can present that to you a few different ways.
Thank you, and I really appreciate the presentation today. Good
Thank
work.
you.
Senator Meredith.
Thank you, Madam Chair, and thank you, Dr. Marks. Great presentation as always. And of all your slides, probably the one that most impactful for me was your Unshamed Kentucky. I never really had considered that element of it, but certainly that is an obstacle for many, many people. And I'm very pleased that maybe we have some technology available to us to address that and in our tool chest. And this is certainly something that all of us seem to have today. And so I'm talking specifically about prescription digital therapeutics. And I know there's been some pilot programs on that, and other states have adopted it. Chairwoman Mosier had a House joint resolution last session to direct Medicaid to seek guidance from CMS as to payment for this. Do you embrace that technology? And if you do you know where we are as long as the payment continuum for this?
Yeah, I do embrace that technology. Their evidence base is clear that it supports engagement in the application, which delivers evidence-based psychosocial interventions. It has the capacity to do contingency management. Sorry, I dove technical. You probably just want a thumbs up or a thumbs down. But yes, in terms of the status, that is on the Medicaid side where it's moving through. I've been supportive of the process. CORE obviously piloted those to demonstrate the return on investment, to show that we need to adopt this one way or the other. And so I would defer to Medicaid on their progress towards it, but other states are moving in the direction of adopting it, and we need all the tools in our tool chest.
Well, I think that stigma is such a huge obstacle, and this certainly addresses it right on. And I appreciate that. Last thing I have for you, not to put you on the spot, but if you view this as an epidemic, which obviously it is, where are we on the curve? Have we peaked out? Have we turned it? Is it still growing?
Here's what I know. I know that we had our highest peak about a few months after the declaration of emergency was declared for COVID. And we shot up in our time, and then we continued to rise, and then we leveled off. And that's where we are right now. We are at a new baseline that remains significantly elevated prior to the COVID-19 pandemic. I do see signs, I look at the data regularly, that we might start to be on a small decline, but we've settled in really firmly to this kind of higher plateau. And with evolving issues like fentanyl and other adulterants that naloxone can't reverse, we've got more challenges to get it to go firmly down.
All right. Thank you. Thank you, Madam Chair.
Of course. We have two more quick questions, and then we're going to move on. We have three more presentations. So, Representative Bratcher.
Thank you, Madam Chair. And I think Senator Meredith answered or asked the question. Mine was, we still rank. The last numbers I looked, we're number one in deaths by overdose in the nation. And that's not a good number, not a good place to be even number one. And we've been at number one for quite a while. So I'm just wondering, when we're going to see results on the hard work we're putting in and the money we're putting into these areas, because people are dying daily because of this epidemic, and it's affecting the economy, it's affecting everything.
Bending the overall curve is hard to say, but what I can tell you is that alone in this program, I can't believe I didn't say this number out loud, we know that there were over 4,200 people that had an overdose reversed or requested additional naloxone because they had reversed an overdose through this alone. And so I can tell you that we would have 4,200 more people dead in this state if we didn't have this program just in the past year. And so and I have to give myself this own pep talk, what we are doing is has limited the rate of increase so far, and that means something, that we haven't escalated like we have. What it takes to get down that's why we're all in this room working on it together. But I know that what we are investing is saving lives.
Thank you. Representative Rourke's last question, and then I know that there are some other folks who have questions. We'll move on, and if you could just save those and roll them into the next presentation, that would be great.
Thank you, Madam Chair. And thank you, Dr. Marks, for your presentation. It's always tremendous the work that we're doing, and also overwhelming at all the various entry points that we have to account for in order to see actual outcomes and prevent deaths in the state. One of the things that I'd like to ask today is, what are the barriers or pushbacks that you're seeing at the local levels across Kentucky that are preventing us from expanding care more?
Yeah, that's a great question. I think that there's structural barriers, right? We don't have enough recovery housing, and so communities can do all of this treatment, but then they either have to send someone outside of their community for recovery housing, or they just don't have it. Transportation is a huge barrier. We can build these services all day long, but if people can't get to them, and this is an urban and rural issue, if you can't get to the location, you're not gonna recover. We know that there's still stigma that's preventing access to quality evidence-based services. So we still have the vast majority of hospitals in our state not prescribing or giving buprenorphine to treat opioid withdrawal. We know that while we are on the verge, we're on the precipice of changing things within our Department of Corrections. If you go into a jail or prison in Kentucky, the vast majority of people are going to have to experience withdrawal and not receive medications. And so we continue to have to build choice and access to those evidence-based services. And then we have a sizable portion of our population that doesn't have Medicaid, which is a really nice benefit. So if you're on Medicare, or if you're uninsured at the time, or you have a really low quality private insurance plan, those folks are falling through the gaps right now.
Okay, thank you so much. I know it's big and there's a lot to talk about, but I think this is a great time to segue into our next presentation.
Thank you.
And we're going to bring up Dallas Hurley he's the Senior Policy Director for VOA, the Volunteers of America, to talk about recovery-ready communities. And I'm sure he's going to give us great background and talk about kind of what is going on across the state to ensure that our communities are recovery-ready. So welcome. If you could just introduce yourself for the record, and please proceed.
Thank you, Madam Chair. My name is Dallas Hurley. I'm the Senior Project Director for Recovery Ready Communities for Volunteers of America Mid-States. We have been chosen, well, first of all, initially I want to issue an apology on behalf of Executive Director Van Ingram from the Office of Drug Control Policy. He was double booked today, but he is at a very important meeting. He is attending the board of directors for the Healing Communities study, and so that's a huge influx of federal support. So it's good that he's there, and I'm happy to try to fill the void and hopefully be as informational as he can be. So just to give all the new members some background, the General Assembly in the 2021 session passed House Bill 7, which established the Recovery Ready Communities Advisory Council. 22-member council, very diverse, folks with lived experience, experts in the field, folks from all the affected departments, local representation from KLC, and so it's a very good sort of broad-based council. This council was tasked with creating a quality measure for cities and counties' recovery support systems and treatment programs. So with that work started, the council initially met several times, I think over about 6 months. And then I think they decided that once they started getting into the technical aspects of actually building a criteria to do these quality measures, that they needed some backup and some extra support. So it was decided through Office of Drug Control Policy to contract with Volunteers of America Mid-States, and that's how I became part of the project. And I'm very excited to report today that we have just, the advisory council has just approved the draft criteria that we proposed to, that we helped Executive Director Ingram develop. So we are right on the cusp of launching this statewide. We are sort of tinkering few last minute tweaks to our website, which that'll be the application portal for communities. So it'll be rrcky.org, and that'll be live. That's where anyone in your community can go to get more information or apply. To give you an overview of the criteria, I'm going to echo Director Hubbard and Dr. Marks, because we had the same three areas of focus. So the first category, prevention, and that runs the gamut from active local ASAP boards to primary prevention in schools that CORE is funding, complementary efforts in the community, such as Operation Unite out in Eastern Kentucky. They're doing a lot of great work to complement that universal prevention programming. Also, harm reduction programs, naloxone distribution. So these are all some of the criteria that we're looking at within the certification criteria. Next, the category would be treatment. And here, again, sort of building on the work that CORE has done in terms of trying to really, sort of professionalize and get as much evidence-based practice or evidence-informed practice in that treatment space. That's what this criteria is focused on, making sure we're using ASAM assessments, which is the Association or the Society of Addiction Medicine. So we'll have a universal assessments. Also, we're looking at overdose response team, the quick response team that Chair Moser mentioned earlier, trying to expand that out wide. And really, from my perspective, and it's a great job as a policy nerd, we're building on the amazing work of CORE and really trying to scale it up and sort of give cities and counties a blueprint for evaluating the good things that they're doing, the strengths that they have, and then looking at the opportunities to where maybe they can make some strategic investments, especially using some of the money that is coming in from these giant settlements. So I think that's really sort of where we fit in on this continuum of all these statewide efforts. And then the final category, recovery support. So Dr. Marks alluded to trying to build up recovery capital, which are sort of the protective factors around folks in recovery or folks in suffering from substance use or in treatment or in recovery. And so really, all of our criteria is designed to increase recovery capital at the human level, so the person affected, the family level, trying to support families in crisis or families with a family member in crisis, and then also at the community level. And really, the strengthening at the community level really looks like at strengthening the continuum of care and making sure that everyone, all stakeholders involved, first responders, hospital systems, public health departments, local chambers, local employers, that everyone receives anti-substance use disorder stigma training, and then they know their role in terms of how to address these issues. And that creates sort of a stronger connective tissue throughout the continuum. So moving on, I did want to bring up, prior to passing the or approving this criteria, Executive Director Ingram wanted us to beta test this criteria just to make sure that we're striking the right balance between being aspirational and attainable. And I think the initial 4 beta tests were successful. Most of the communities were within striking distance. I mean, there's some gaps, but really what we're excited that we think we've got a good blueprint for communities to really dive deeply into what are our responses? What can we do better? How can we better serve this vulnerable population? And then finally, I would like to thank not only Dr. Marks, but just a myriad of people. We were on a 6-month blitz across the Commonwealth, trying to get as much input, as much stakeholder advice, expert advice, advice from the folks that have lived through this. And it's been an amazing experience, and in all honesty, very heartening. I mean, this is a tragedy. This is rough stuff. But to see what is going on the ground level, and to see the people that care, to see the people that are maybe putting away their biases and really just stepping up to just try to help their neighbors recover from this. To see like local chambers of commerce and employers stepping up, being involved in the transformational employment efforts. It's very heartening from my perspective. And I hope that I'm a good booster for you all in terms of really promoting this program, because I think this is a key or a way to scale and build on the successes that we've heard from CORE. So at that, I'd welcome any questions. And I can actually talk about the application process. So we've got, we'll have the website up and running. Now, one of the features of the website, we're going to link directly to the Kentucky Injury Prevention Research Council, KIPRC. They are amazing. They have been they put out this dashboard with all of our overdose data from 2017 to 2021, and you can actually use this dashboard to drill down at a county level, and you can see everything that's happened from 2017 to 2021. So I highly encourage everyone all of the members to check that out, and also send your judge executives and your mayors and anyone on council or fiscal courts. I think that's sort of the starting point. You got to know what's happening, what's been happening, the trends. So very thankful to Dr. Bunn and her team, and for letting us link to that information. It's an invaluable resource. So once a community makes that application, and the application's open to anyone, the Advisory Council is encouraging communities to sort of designate one person, but maybe create like an ad hoc team or a multidisciplinary team, because this criteria spans, like I said, everything from hospital systems, treatment providers, recovery community centers. There's a broad, the court system, everyone's at the table. So we really need, I think the successful application will be where we have as much input as we can from across different practices, and that'll make everything a lot smoother. So the application will be made. My team will review the application initially, then we'll work with the community to schedule a site visit. I think that site visit's going to sort of be twofold. Make sure that nothing's changed since the application, and that the conditions on the ground are the same. And then also to be able to seize like some innovative models that might be scalable in other communities that we could highlight. Again, sort of that booster role. So once that site visit's over, we'll come up, my team will work to provide a recommendation to the Advisory Council. And ultimately the 22-member Advisory Council will make the final decision on the certification. In the event that a city or county or group of cities or counties aren't certified that initial attempt, we will offer our support in the form of technical assistance to work on any gaps in that application process, and maybe provide some more innovative models that might be scalable or might be workable in those communities. So really, this is about collaboration and really just bolstering the good work that's already been done across this Commonwealth. So thank you.
Thank you so much, Dallas. It is heartening to hear about the collaboration that's going on across our state, and I think that when we talk about this project, it's not just creating a blueprint, but it's putting together that multi-stakeholder team in each county or each region. And I know that some urban areas, like Northern Kentucky, we have the Office of Drug Control Policy. Fayette County has something similar, Jefferson County as well. But for the smaller counties who don't have something that's organized yet, putting together this team really helps do a broad assessment of what's in place, what resources are needed, and putting together that blueprint. I love creating partnerships. I love that this is also working in tandem with KIPRIC to look at and follow the data as it comes available. I think it's a really kind of comprehensive program to put a continuum in place. So thank you for your work. And I think your talk now is a great segue to another project that's going on in the state. And I hope that everyone is starting to see kind of how all of this interplays. And we've got a lot of different things happening, but they all are working together. So thank you for your work. I know that this is not the last time we are going to hear from you. So I love the work that VOA is doing as well. So, all right, thank you. I don't think we have any further questions. I'll invite Laurie Givens and Rachel Bingham to the table now to talk about another aspect of this. And Dallas touched on this in his comments about how the court system is often involved in individuals who are suffering with a substance use disorder and mental health issues, often co-occurring. And because individuals are often justice involved, I was really honored to be part of a team this summer, and I've talked about this a little bit before, but that traveled to Texas to talk about the intersection of the justice system in dealing with mental health issues and substance use disorders. The Supreme Court has an AOC, and I'll allow you to introduce yourselves here in a second, but has done a great job in putting together a judicial commission to really look at this holistically. So thanks for being here. Introduce yourselves for the record, and I'll let you get started.
Madam Chairman, thank you very much for the invitation to be here today. My name is Laurie Givens, and I am the Director at the Administrative Office of the Courts, and to my left is Rachel Bingham, the Director of our statewide services programs, which includes pretrial, our specialty courts programs, and our family and juvenile services programs. That trip that we were able to take together this spring to Austin with Chairman Westerfield also as the other legislative member really was the tipping point for us, and that led to the creation of the Kentucky Judicial Commission on Mental Health. And I think typically when you see court involvement, you see court involvement on the back end, and historically you've seen it in Kentucky, court involvement on the back end in a drug court program in each of your communities statewide. But where we haven't really had a lot of consistency, and I think where we're probably seeing the puck start to move, is towards what is a more holistic behavioral health model, what is more front-end work by the court systems, and really a greater focus on mental health, the intersection of mental health and substance use disorder, and intellectual and developmental disabilities. And Rach, I just want to say you set us up perfectly with the word collaboration at the end of Dallas's presentation, because that is the whole purpose of this project. This is not a General Assembly funded project. However, it is bringing together all of the resources and programs that you have put in place and trying to get us all in one place to address more support for this population. But our commission's overview, as Chairman Moser has already mentioned, was established by Supreme Court order in August 2022. And our goals
Will you
are
pull
to...
your microphone just a little closer?
Yes, sorry. I sound loud to myself. Apologies. Thank you. But the Commission's goals are to explore, recommend, and implement transformational changes to improve system-wide responses to justice-involved individuals experiencing mental health, substance use, and/or intellectual disabilities. I think the language there is very important because we spend a significant amount of time, and we have in the courts, talking about substance use disorder. But what we frequently see is a population that is also suffering from undiagnosed and previously untreated mental health issues. Rach, go ahead.
So I'm going to kind of just give you some background and some history on how. Am I on? Oh, I thought I was on too. On how we decided to really take a hold of a lot of the work that's happening across Kentucky and a lot of the conversations that we've been able to have with leadership. And, you know, as you heard from Dr. Marks with the CORE initiative, we have been privileged over the years to partner with the Cabinet for Health and Family Services regarding their efforts around CORE. And that partnership has typically been around ways that the court system internally can really educate ourselves around substance use disorder. How can we be able to collaborate and provide resources to our local judges? What can we do to educate and expand services to our specialty courts? And so this work has really given us an opportunity to collaborate in a way that we never had before. And it really took us down a journey of looking at how the court system can become more of a recovery-oriented system of care, intentionally looking at any door that those that we serve enter, we can be able to provide to them some sort of bridge to resources, services, some sort of opportunity to have access, whether it's substance use disorder, mental health issues, or developmental disability. So we looked at that from two different spaces. It's taken us about 3 years to really dive into that. Looking at readiness for the court system, were we in a place that we could honestly be able to dive into this work? And then we also wanted a plan on how we could accomplish that. And so some of the first initial products that we had were really to be able to build our capacity to understand what a recovery-oriented system of care would even look like in concept for the court system. This took us, and we are excited about the fact that the court has really taken such a leadership role. We have had the honor of working with Justice Deborah Lambert, who was unable to be here today, to be able to really lead this work. And so the commission itself and the framework that was built around it with her leadership, and we actually have Circuit Judge Larry Thompson, who is the co-chair of that particular commission, has been an opportunity to really bridge and expand the resources. We would be remiss to not mention that a lot of the folks here in the audience provide us some staff support and some collaborative opportunities that we'll dive into.
Go ahead. So it's a large commission. So we have 74 appointed members. However, even beyond that number, we have a lot more involved. Once we announced the formation of the group, which initially was much smaller than 74 members, we started receiving a lot of phone calls from folks who wanted to be involved. And there's no way to tell anyone no when you begin a project of this scope and this magnitude. So we have really taken an approach where reach out to us, because we know there is a place for you, no matter what your background is, no matter what your perspective is. But the commission is a combination of judicial members, legislative staff members, community stakeholders, treatment providers, folks in the communities, and law enforcement, I think, playing a critical role also on this task force. We have there's a link in your presentation materials to the order, but as Rachel has already mentioned, collaboration, we think, is the key. The commission meets quarterly, and we had our meetings this year were September and December, but we anticipate March, June, September, and December, and are really trying to work around the legislative calendar to make it possible for the legislature to be as involved as possible. So much of the work is going to happen in all things on committees. So this is the structure of the Mental Health Commission. We have 3 large committees encompassing criminal justice, civil and family justice, and treatment and access. Each of these committees has separate work groups. So suddenly you see those 74 members on this committee. Everyone has found their area of interest and are contributing in a significant way. We're moving quickly. I feel like on this project, we are moving towards really what short-term objectives and long-term objectives are. But Rachel, I think with the next slide, we'll show them exactly what the structure looks like. Sorry for the small print. But you can see the lead on each of these work groups. We have a number of folks. You can see names I know that you recognize: county attorneys, jailers, some of our own judges. And we've got folks from the Cabinet for Health and Family Services, many of whom are in this room right now, leading several of these work groups.
Not to make a plug, but if anyone is interested, we are encouraging participation, in particular around the committee and the work group efforts, because it's such a broad scope of content areas and things that we really want to make sure we have the experts in the room. So please share this information if you yourself are interested. We definitely have a place for everyone.
And I want to just say many of the statutes in this area haven't been looked at for 50 plus years. So these groups and these work groups are going to be taking a look at some of this legislation and seeking your input and guidance on what recommendations might look like.
So this is what it looks like in basically our short-term goals. As you can tell, any type of multidisciplinary commission like this is all about communication and collaboration for the court system to be able to really engage with the partners. We want to expand and increase the educational opportunities that we have. We also want to make sure that we look at how we're efficiently partnering on resources, services, supports. You know, we're taking notes even when we listen to the core presentations and recovery ready presentations, just to figure out where are we potentially missing connections and opportunities to provide information to the commission. We want to make sure that we can also help around efficiency and capacity building, and we've been very intentional to do some work around some of our national partners so we can provide TA from them or receive TA from them. You mentioned there was mentioning of sequential intercept mapping. We're very intentionally doing that work on the criminal justice side as well as juvenile justice and dependency, neglect, and abuse. Long term, it is just, as you can just see from the capacity itself of those that are represented in the content areas, is really about trying to figure out and find ways for earlier identification and support, capacity building for those individuals that come in contact with the court system and justice system in general. Really find ways to be able to invest more in diversion programming. You are going to get a great presentation from our colleagues around Senate Bill 90. That's one of those examples of those opportunities. Find ways that we can look at funding and chances to build more capacity in our communities, and then to make sure that we really consider that service array, and that service array is accessible to people that need them, and that the communities have the opportunity to really build upon that service array.
So this is our last slide and our plug for the first annual Mental Health Summit, in which you will all be invited, and we're hoping that this is a date that you can attend. We're anticipating a large crowd. We're going to build community teams and partnerships, because I think all the work here is going to happen in the communities. It's an opportunity to gather all of the stakeholders together in your branch, in our branch, in the executive branch, and our partners at the local levels, from the treatment providers, law enforcement, our prosecutors, our public defenders, and really advocates in this space as well. We're excited about following what was the Texas model that we first saw. We're one of the first states to form this commission and also to host a mental health summit in a little bit. And I know there are a lot of new members on this committee and a new committee. But for those of you who don't know, the Administrative Office of the Courts is the support arm of the judicial branch, much like LRC is to you. And we have 410 elected judges and circuit court clerks statewide and 3,500 employees statewide. But we're one unified judicial branch with one budget, and our Chief Justice is our administrative head. So this has the support at all levels of our court system and our commitment. And I just want to thank you for your partnership with us over the years and your support, because it's your leadership that I think is so critical to the success of this commission. And I just want to thank you all, and happy to take any questions. I did bring a recent map of our early beginning on where our family treatment court programs are and where sort of our patchwork quilt beginning of mental health courts are. I think we'll see recommendations from this commission that are going to encourage expansion of both of those programs, by the way.
Thank you so much. I don't know if the members here really understand my involvement historically and why I'm interested in this. I am a nurse, but I also served as drug policy director for a lot of years. And so I saw that the individuals who were being routinely incarcerated suffered with a mental health or a substance use disorder. In fact, I think the number, I don't know how current this is, but it's been in the 80% range. About 84 to 87% of inmates who are incarcerated because of a mental health or a substance use disorder. And that is unacceptable. We understand that the court is often on the front lines of this, and so it just makes sense to take a look at how the court system, in collaboration with all of these stakeholders that Laurie talked about, can come together to really address the needs of the individuals, because it affects everyone downstream.
Well, and we're really trying to focus too on an area that we don't think has received as much attention the last few years, but certainly is now, and it's juvenile mental health issues. And that's where we have the intersection. It isn't just necessarily in our criminal courts. It's in our dependency, neglect, and abuse docket. It's our juvenile court docket. It's our family court docket. We're seeing it in every courtroom in the Commonwealth, and early identification of folks who are in need of services of what's important. And that's our goal. And in so many ways, Madam Chairman, the segue to the next presentation on Senate Bill 90. But we're happy to take more questions, but I also know you guys are.
Okay. Yeah, I just have one more
Sure.
quick request, and yeah, I think Senate Bill 90 is an excellent example of some of the policy decisions that we're going to talk about. I know what sequential intercept models are. Could you just elaborate a little bit more on what that is, just high level, the different categories?
And we should have included that in the presentation just for a reference material. And Dr. Marks actually had an example of each of the intersection points in her presentation as well. But the sequential intercept map is where we come in contact with individuals along the way in the system. And, intercept point 1, and as you may have seen in Dr. Marks's presentation, she had that slide, is usually with that crisis response team in law enforcement. So really the court system is a later intersection point along the way. But Rachel, I don't know if anything else you want to add on.
And I think the important part is that at each time you're looking at where's the opportunity to intercept, to take a different direction, to potentially do things slightly different, some unique approach, some opportunity, instead of moving someone through the system and having to have them enter the court system to even access a service or a resource.
And you heard Director Hubbard mention how important the expungement piece is in future employment. So what if we are able to intercept these individuals earlier, before a conviction, before a sentence, before the period of time, they wait in the event they have an eligible charge to be expunged. So it really is about redirecting much earlier in the process.
Right. Yeah, thank you for that. And there's so much that we could talk about. We could really get in the weeds, but that's what the commission is for. And I would just encourage everyone to come to the summit at the end of May. You said June.
May 31st
first part
through
of
June 2nd.
Right, and I believe we should be pretty ready with some mapping to talk about the resources and policies that are in place now, and to really get a little more direction. So,
I think so, and it hopefully
Yeah.
gives us time to plan with you for the 2024 legislative session.
yes, exactly. Senator Funke Frohmeyer.
Yes, thank you, Madam Chairman. And Laurie and Rachel, beautiful. This is a conversation Monday morning that I had with a constituent in my community. And without taking an inappropriate introduction, I wanted to understand an appropriate introduction. Would you want to meet those constituents that are maybe didn't hit the intercept point and head the direction that they wish they would have headed, but perhaps they could provide some great life experiences to exactly what you're sharing, from the arrest to the conviction to the current incarceration? Not they themselves, but one of their family members.
I think their stories are critical to telling the story. I think this is absolutely about telling those stories. And Senator, we would be more than happy to meet with you and your constituent anytime, and happy to travel to Northern Kentucky as well. We do have staff there. We do have a mental health court program there. But again, many of our court programs there are the back end of the system. So I think we would be happy to meet with you and your constituent.
Yeah, their heart today is to help prevent others from their experience, but they still have some work to resolve. But in the contact that you shared in the
Yes.
presentation, is that the appropriate contact to connect with you?
It is, and I believe staff can also connect you with us individually, and we're happy to share cell phone numbers. I think for many of the new members who may not have our cells yet, I'm absolutely happy to share that. I know several of the members who've been here for a little while do have that, so we're available to you anytime.
Thank you.
Okay. Seeing no further questions, thank you so much. These women and your teams are just invaluable resources, and Very proud of your work, so thank you. Okay, next we're going to hear about the Behavioral Health Conditional Dismissal Pilot Program, also known as Senate Bill 90. And we have Angela Darcy, also with the Administrative Office of the Courts, and Jason, well, no, Jason's not here. I'm sorry. All right. Okay, so if you can just introduce yourselves for the record and proceed. I really appreciate your being here today.
Sure. I am Angela Darcy, and I am the Executive Officer of the Administrative Office of the Court's Pretrial Services.
And good afternoon. My name is Brittany Allen. I am the Director of the...
Your microphone's not on.
There we go.
Thank you.
Brittany Allen, Director of the Division of Substance Use Disorder within the Department of Behavioral Health, Developmental, and Intellectual Disabilities.
So it is my honor to be here today. Thank you for inviting us. I want to talk a little bit about Senate Bill 90 and kind of where we are at with implementation so far. I'm extremely excited to talk about Senate Bill 90. As a former public defender, I would say that Senate Bill 90 is much needed. And I was in Pike County in eastern Kentucky when I was a public defender, and many of my clients suffered from substance use disorders or mental illness. So it's exciting that we finally have a bill of this impact, and we will go ahead and get started and talk a little bit about it. So for all of our new members, Senate Bill 90 is basically a bill that seeks to divert people from the criminal justice system that have substance use disorders or mental health disorders, and it diverts them from the system and gets them into treatment right away. They have to meet a series of criteria, and we will take that defendant in pretrial services, we will assess them, and then within 72 hours, they will get a clinical assessment if they qualify. And the clinical assessment will then determine whether or not they do have a substance use disorder or if they have a mental health illness. If they do, they are eligible to participate in the Behavioral Health Conditional Dismissal Program. So the program lasts a minimum of 1 year, but it can last up to the maximum sentence that the defendant is sentenced. So there will be defendants that, with the misdemeanors, that may not be the minimum or the maximum of 1 year, but they can also agree to participate and extend and waive that requirement. So defendants have the ability to say, yes, I would like to participate in this program, and then participate accordingly. One of the good things about this bill is what it does for the defendant. So it offers wraparound services. So it's not just treatment, but we're also looking at housing. We're looking at potential jobs for these defendants and giving them just the opportunity to succeed. These are low-level defendants, so they are low-risk defendants with our pretrial services, which would be low risk for failure to appear and low risk for new criminal activity. So these defendants have an opportunity to go into this program, not have any charges. They're charged with a crime, but the charge is held in abeyance. And if they complete the program, then the charges will be dismissed. So it's really a good opportunity for defendants not to have a criminal record. And there are some Class D felonies that are eligible for this bill. And that's pretty critical in this process because, as we all know, once you are convicted of a felony, it impacts the rest of your life. So this is a pretty important bill for these class of defendants. It'll allow them to get treatment, potentially a job, housing, and kind of follow up with them. And if they're successful, they don't have criminal charges and the charges are dismissed. So we have, the bill also provides for an implementation council, and if you can look from the slides that we provided. These are all the members that are on the Implementation Council. We did the Implementation Council added an ex officio member, which was somebody from the Kentucky Adult Education. The executive director is a ex officio member because they play a big part in this bill. So we thought it was really important, or the council thought it was really important, to have them at the table. So much like every council, we have work groups, and we have a series of work groups. The Implementation Council has designated the Courts and Data Reporting Work Group. They do a lot of the data mapping. They also look at what we need to capture in data fields and what we need to create for reports. So as a result of the courts and data reporting, we have created a series of forms, and I believe in your packet you probably have one or two of those forms that we've begun to create. And we have a 14-day report that we're working on, a 28-day report that we're working on. BHDID has been really working alongside us with this and helping us create these reports as well. We also have a treatment and recovery services, and Dr. Allen will talk about that.
Sure. So the commissioner of our Department for Behavioral Health, Developmental, and Intellectual Disabilities chairs this treatment and recovery services work group. And so our department did take the lead on developing a number of the different pieces that you see listed on the slide here. But we did so in close collaboration with AOC. Also, Medicaid treatment providers are a part of that group, and also some other key stakeholders. Notably, we have worked to establish the clinical assessment process, which, again, as Angela mentioned, is required to determine participant eligibility. We're also working through determining how we're going to link these individuals to services. Also planning for engagement and onboarding of treatment providers. I'll talk a little bit later. There are some specific criteria for providers and specific expectations for them, and so we wanted to be sure that they had all the information possible to be onboarded into this program. In addition to that, we're working closely with Medicaid to ensure that there's viable reimbursement structure for a number of different pieces, but namely the assessment process.
And then we also have the Education and Training Work Group. That is a series of members from vocational rehab, adult education, and then other members. And they are working together to piece together the second component of the bill, which is education and training for the participants in this program. So we have identification of 11 pilot sites. The bill required us to establish, or required the Supreme Court to establish 10, and the Supreme Court established 11. So we have Christian, Clark, Davies, Greenup, Hopkins, Kenton, Letcher, Madison, McCracken, Oldham, and Pulaski. We reached out to all the stakeholders that would be involved, and this is how the Supreme Court made their decision. We reached out to all the stakeholders. We reached out to prosecutors. We reached out to judges. We reached out to public defenders and treatment providers. And as a result, we built the 11 counties based on the support from the community, because we thought it was really important, and the Supreme Court thought it was critical to have support from the communities, because without that support, the infrastructure would fail. So currently, we are just now rolling out in Letcher County. We are, the funding is still in
flux. The funding is still in flux at this point, and I'll touch on it a little bit later, but we're very grateful to receive an appropriation with this legislation, $10.5 million in opioid settlement funds every year that the program is operating. At this point, we have established the MOU with the AG's office. We've set up accounting codes. We're literally just waiting for the money to drop into our coffers so we can get going.
So it's been really good in a way, because it's allowed us to do a really slow rollout, and we've started in Letcher County. And one of the reasons that we started in Letcher County was because the providers were basically saying, look, we are so invested in this, and the judge was so invested in this, that they wanted to go ahead and get started without worrying about the funding. So these providers, in some situations, they're doing assessments and they're starting on the treatment. We only have currently, we thought what were 4 eligible defendants. We actually have 1 eligible defendant who today we believe is going to enter the program. So today we're actually going to have our first defendant. So we're really excited about that. But one of the
Going the wrong way. No.
you're right.
Just keep going.
So we also conducted a bunch of community forums. We did a tour of the state, so to speak, and our staff was there from pretrial services. We had AOC, we had BHDID, and we conducted all these community forums in which we presented the bill. We talked about how our process was going to go, how we were going to roll that out, and we received a lot of questions and a lot of feedback from those community forums. Here's the eligibility criteria. So this is what pretrial looks at to determine whether a defendant is eligible for this program. They have to be at least 18 years of age and a Kentucky resident. They have to be a low-level offender, meaning that they have to be low risk for the FTA, and they also have to be low risk for new criminal activity. They have to be charged with a qualifying offense. There are some exclusions, as you can see there. They have to have a clinical assessment that indicates that they have a substance use and or a mental health disorder, or if they don't qualify through the pretrial risk assessment or those above qualifications, the prosecutor has the ability to do an override. So if the prosecutor sees somebody that they think would be really good for this program, the prosecutor is allowed to recommend them, even if they might not be eligible on our pretrial eligibility criteria. But they still have to indicate that they have a substance use disorder or a mental health disorder on that clinical assessment. The next one is just an overview of the form that we have created for the pretrial eligibility screening. I think that it is important to note that even though we have not rolled out in the counties yet with the program, we are conducting this eligibility screening as we speak in all 11 counties. So we know who is eligible as of this moment, and so when it rolls out, we will be able to offer these services to them if they elect to participate.
Mm-hmm. So the other key component in determining eligibility for the program is completion of a clinical assessment that's going to indicate the likelihood of that individual having a substance use and or mental health disorder for which they should be referred for treatment. And as was mentioned earlier, the legislation does require that this assessment take place within 72 hours of being booked into jail and being referred into the program by pretrial or by the Commonwealth attorney or by the client's attorney. And as you can imagine, 72 hours is a pretty quick turnaround for a lot of our providers that are contending with some significant workforce challenges and some other limitations as well. So what we're doing to remedy that is we're establishing an assessment entity that can provide assessment services pilot-wide. So for every pilot county, this entity can provide that assessment process. In addition, we're creating an alternative for those counties that maybe already have a diversion program in place. They're already working with an entity that's providing a similar assessment service, and so we want to be able to leverage that existing infrastructure and relationship and provide an extra level of flexibility for those counties specifically. So we've released an application for those entities that are interested in serving as a county level assessor to serve in that capacity for those counties that are in that situation. But if a county does not choose to have a county level assessor, that's completely okay. We will have that pilot-wide, statewide assessor that can provide that service. Now, after that clinical assessment is completed, the qualified mental health provider has 48 hours to submit treatment referral information. So that is what level of care is that individual going to be referred to? What provider is that individual going to be referred to? So whether it's the pilot statewide assessor or whether it's the county level assessor, they're going to do an initial screening and a brief assessment. They're then going to provide a referral to a behavioral health provider at that appropriate level of care, and that provider will complete a full biopsychosocial assessment in order to develop a treatment plan and engage that individual in services. I mentioned it earlier, but I do want to note that participating providers are required to meet specific criteria as part of this program. Specifically, the legislation outlines that they have to meet licensure criteria that's set out by the Cabinet for Health and Family Services. They have to be a Medicaid enrolled provider, and they also have to meet at least one of 3 specific accreditation criteria. And this is accreditation criteria that specifically indicates that they are able to provide quality services to these individuals. And we've also established an application process by which providers that are interested in providing services as part of this program can attest that they do meet these criteria, that they have the necessary experience to deliver these evidence-based services that are outlined within the legislation, that they can provide linkage and referral to recovery support services as part of this program, including housing supports, including employment supports, and also that they have the capacity to meet the programmatic expectations of this program. So there's data collection components, there's reporting components, and these are all key pieces that they have to attest that they are able to do.
Speaking of data, the AOC was allotted, I believe it was about $500,000 in the bill for the administration of our data collection. So that is one of the reasons that we created all the forms, because we at AOC are going to be collecting all the data and reporting that back to the legislators every year. And so currently we are working on software for that. Right now we're just doing a manual collection, but we hope to have a program soon on behalf of AOC. Additionally, BHDID has also been working with that, and if you'd like to talk about that, Dr.
Yeah, I'll just mention briefly, as Angela mentioned, we worked very closely to develop those data forms, both our department and AOC. We also got feedback from Medicaid. We also got feedback from treatment providers. And then we are also, our department, establishing a data collection platform that will make it really easy and streamline the process for providers to enter the required data points, and then also at those appropriate time points, as well, as there are many. All right, so I am just going to, again, just make a plug. We are very, very grateful to have the appropriation of funding for this program. There's a lot of components here that require some additional assistance. The primary goal with the funds is really going to be to support reimbursement for direct client services. That's really where we want to focus the bulk of this funding. So that could include the covering of assessment costs, that could include the covering of treatment and recovery services, particularly for those individuals that don't have private insurance, that are not Medicaid eligible, and don't have a third-party payer source of any kind. We also plan to use funds to cover those non-reimbursable costs, transportation, recovery housing, job training, all things that we've heard from the other presenters are really key barriers to these folks maintaining long-term recovery. So we do want to make sure that those supports to build recovery capital are in place. And then we're also, of course, going to need to use some funds to support those administrative costs. So staffing, building out these data collection platforms, and any other necessary components necessary for successful startup and ongoing implementation of this program.
So that leads us to our next topic is administrative support. So Kentucky Administrative Office of the Courts, through pretrial services, has hired several positions. I think we're going on 3 now to implement Senate Bill 90. Since we just started in Letcher County, I've had those staff in Letcher County to kind of see how the process goes to work out some of those kinks. But we've created a statewide operations supervisor we're hopefully going to have 2 of those positions. I'll explain what the second one will be doing shortly. Our first statewide operations supervisor, Stephanie Rio, is overseeing the implementation of Senate Bill 90. She is working with providers, she is working with the judges, she is working with the local communities, she's working with pretrial services to kind of get this up and running. And then we also have a regional supervisor who is providing support, Amy Rouse, to Senate Bill 90 for Stephanie, and Amy is doing all basically the administrative support, but also is out in the communities talking with these providers, trying to get the kinks worked out early in the system so we can have it up and running pretty smoothly. And we are working on training with our staff. Our staff, like I said, with pretrial services, we are fully doing the eligibility assessments. We have discovered there are, when you do a manual process, we've discovered, some errors. We're working on correcting those so we can have it perfected, and we're almost there with perfection on the eligibility criteria. The next steps, I think Dr. Allen can talk about.
Yeah, sure. So obviously no pilot or startup is without some initial barriers to implementation, but our department, AOC, other stakeholders, we have persevered and we continue to push forward, and I know we're all committed to getting this up and running in all counties as soon as possible. As I mentioned earlier, we're waiting for those funds to come down. We have the contracts prepped and ready to go. Once that funding does become available, with regard to providers, we released our first approved provider list last week. We continue to get additional applications, and we are certainly pushing it out into the communities and ensuring that we can engage as many providers as possible into this program. We want to make sure that folks have optimal choice, plenty of choice when it comes to what provider they choose to go to receive treatment. Again, with regard to the assessors, we have just, I think yesterday, the application for county level assessors wrapped up. So we're going to be meeting with AOC and also some county level stakeholders to make sure we get their opinions and who is awarded that county level assessor distinction. And then also we're establishing that contract with that statewide entity that's going to be able to provide assessment services across all of the pilot counties.
And we're looking at ongoing training for all our local stakeholders. That's something that we've been working on, is developing a training process for them as they get into Senate Bill 90 to kind of explain and guide to them how the process is working. And then we are also doing a process map. So I believe in your package you have a brief process map of Senate Bill 90. And so we're constantly tweaking that process map and refining it to get it right. And what I'm really excited about is our case navigators, and I'll talk about them next. So one of the things that when we went to all these community forums, everybody talked about needing support. They needed a person that was allotted to that specific county that could support them with Senate Bill 90. So we have, in conjunction with BHDID, have been able to secure funding for case navigators. And the case navigators are going to be critical to this. They're going to kind of take the defendant and take them through the whole process of the behavioral health conditional dismissal program. So they are going to help coordinate services. They may work with the case managers from the treatment providers. They'll be kind of the one-stop shop for the defendant. If the defendant's having issues, they'll be the source for the defendant, and just kind of helping them, holding their hand, and walking them through this process. Since these are substance use disorders and mental health disorders, these case navigators are going to be critical because these are people that will be equipped to deal with people with these disorders. And so we have just made our first request to fill the first 3 case navigators, 2 for Kenton County and 1 for Letcher County. And so we're hoping to get them up and running in the next, hired and then trained. And it's going to be it'll be a good learning process for everybody, because this will be critical to this. To us, the case navigators are going to be the one piece that is critical to the success of Senate Bill 90. So thanks to BHDID, we're using the Comprehensive Opioid Stimulant and Substance Abuse Program funds, the COSTAT funds, and then we're hoping not to have to tap into Senate Bill 90. We're hoping to continue to get grant-based funds for those positions throughout the 4 years. So that's something that we're actively pursuing. And any questions?
Okay. Thank you so much. You were so thorough that we don't have any questions. Oh, Representative Whitten.
I just had a quick question on when you talked about your eligibility criteria, the override, the prosecutor override, would that apply to disqualifying offenses like felonies, or would that just be?
So we have, and that was something that we sought guidance from the Implementation Council, and it is basically whatever the prosecutor determines is an override. They have the discretion to allow that defendant in. I don't think in Letcher County they had some potential for prosecutor overrides, but I don't think that they have elected to use those overrides. So I think that they will be used sparingly, but definitely probably appropriately for defendants that have any substance use or mental health disorders.
Okay. Representative Burke.
Thank you so much. I was really pleased to hear your presentation today. I have a quick question, may I ask, Co-Chair, regarding the case navigators. Sorry, not care navigators, case navigators. You rightly ascertained that the population that's being served will have personalities, difficulties, challenges that will make them need really capable case navigators. So my question is, are there specific education, credential, or training requirements for the people who will be serving in the role of case navigator?
So we are building that job description as we speak, and the answer is yes. We're hoping to really, so we kind of have two goals, and one of our goals is to open it up to defendants that have, or not to defendants, sorry, to people that may have had a criminal history before but have a peer support background or some background in substance use recovery or mental health issues. And so the answer is yes. We're also looking at, we have our typical requirements with AOC, which is it requires at least a 4-year degree, but we are also seeking and specifically hoping to target people with that expertise.
Thank you so much.
And then Representative Sharp.
Thank you, Madam Chairman. After they complete this 1-year program, what happens to people who participate? What's next?
So, I mean, that's a really good question, and there isn't specific language in the bill, but I can tell you that with our Mental Health Commission and with those case navigators, we are hoping to kind of stay with those people in the sense of just checking in with them and seeing how they're doing. We know it's not a one and done approach, and so what we're hoping is that we can continue to kind of care about these participants and just track them and make sure that they are still being supported through this process.
So you don't have anything in concrete yet, but this is a goal that you're trying to achieve?
Exactly.
Okay, thank you. Thank you, Madam Chair.
You're welcome. Thank you very much. This was a great presentation. I really appreciate your being here and all of the work that you've done. It's great to hear how we're moving forward on implementing this really important program. We have one individual who has signed up to speak. We are technically out of time, but I'll give you a few minutes. If you can keep it really short, I would appreciate it.
I will be short because we don't have a whole lot of time.
That's right. If you could just introduce yourself for the record.
Okay, my name is David Royce, And
Can you come a little closer to the microphone? I know it's
Yes.
tricky. Thank you. Thanks,
Okay.
everyone.
my name is David Royce, and I'm with, I started 3 years ago, Stop the Drug War and Start the Recovery Process. We cannot afford to lose another child. I lost my son 2 years ago to fentanyl, and it's past time to start treating our sick. I want to thank all you all for having this meeting. I want to thank everyone out here for all the work they're doing to save their lives. We, the parents of the 2,250 Kentuckians that lost their lives last year to fentanyl, don't want it to happen to anybody else. It doesn't happen to anybody else. The infrastructure to treat them is already there. All we have to do is open up every EMT station across Kentucky. Every morning, the drug addict could go in and get a safe dose of medication, go home, come back the next morning, get a safe dose, and we'd be able to talk to them and counsel them, and possibly someday they may become one of the best people on this earth if they're allowed to live, if we treat them. And I want to share this quilt I made. This quilt is a giant SOS. And the stars on the back of this quilt represent, there's 2,250 stars on the back of this quilt. That's how many Kentuckians we could save every day, every year if we treat them. And I feel like that it's past time. We all know that it's past time to start treating them. We all know what an emergency it is. And so I challenge each and every one of you senators and legislators to get on board with treating our sick. It's just unconscionable that we're sitting idly by every day and watching 5 or 6 more Kentuckians die. 280 Americans die every day from drug overdose. And we can treat them, and we can set these up. I've talked to the fire chief in Lexington, and he says, yes, it's a great idea. I talked to Gary Ginn in Lexington, the coroner. He said, once we recognize that a drug addict is sick, it's our job to save them before they die. He said, I've had 39 people this year from 17 to 68 that have died from drug overdose. It's past time to do this. We have to do it. Reginald Thomas signed this quilt. He said that he's going to get on this when the legislative session ends. He don't have time to fool with it right now. Lindsey Burke has signed it. Several other people have signed it. And the opioid monster knows no bounds. He will claim someone you know sooner or later. This is not a partisan thing. This is life itself. And we need to make treatment today, immediately, available to them. And I challenge every one of you all, or ask every one of you all, if you want to help us save our sick, this giant SOS, you're welcome to sign this quilt to show our support. Thank you.
Thank you
Any
so
questions?
much. Yeah, thank you so much, Mr. Royce. I really appreciate your being here today. I'm very, very sorry for your loss, and I'm glad that you could be here today to see all that we are working on in Kentucky. And I wanted to give everyone kind of an overview of what we have in Kentucky and how we're looking to expand it. So, you know, every policy, every resource is a tool in the toolbox, and we need to make sure that we have all of the tools that we can to save our sick. And I agree that addiction is a sickness. It's a disease, and so I appreciate your work, your advocacy, and thanks for being here. Thanks for speaking up.
Thank
We
you.
will absolutely consider all of the tools.
Well, I urge everybody to make it happen as quickly as possible. Because like I said, every day, 4 or 5 more Kentuckians are dying from fentanyl. So
Thank you.
let's
Thank
make it
you.
happen.
All right. Thank you, everyone, for being here today.
Madam Chair, before we adjourn, I'd just like to remind
Absolutely.
our Senate members that our next committee meeting will be Wednesday, February 8th at 10 o'clock. Obviously, you'll get an agenda, but just want to go ahead and put that on your calendar if you would. Thank you. Thank you, Madam Chair.
Thank you. And the House, the next meeting of the House Health Services Committee will be February 9th at 12 noon. So mark your calendars, and we will start in earnest hearing legislation at that point. Thanks, everyone, for sticking with us today. Seeing no further business, we are adjourned.
And on the Senate